Well, welcome to this presentation where we're going to be looking at the anatomy of the heart. Now, the heart is a hollow muscular organ located in the thoracic cavity. And if you close your fist, your heart is approximately the same size as your closed fist. The average weight of the heart in women is about 250 grams and about 300 grams in adult men, and it's sitting on the diaphragm, and it's near the midline of the thoracic cavity. So if you draw a line straight up and down the middle of the person in the symmetry line, it's near the midline. And actually, people tend to think the heart is on the left. Well, there's truth in that, because about 2/3 of the mass of the heart lies to the left of the body's midline. So 1/3 of the heart is on the right, 2/3 of the heart in terms of mass is on the left. And here we see some of the anatomical relations of the heart. So it's in the thoracic cavity, and at the front it's more or less covered by the lungs. So if you take the front off the chest, that's what you'll see. You'll see the lungs on both sides and the heart in the middle. At the bottom of the lungs, you've got the diaphragm, and as we've said, the heart is actually sitting on the diaphragm. On the right side there, we've got the liver, and on the left side, we've got the stomach, and you can just see the green tip of the gallbladder poking out below the liver there. So there we have the heart, the hollow muscular organ in the thoracic cavity. And of course, as you know well, its functions are to receive blood from the lungs and the body, and to pump blood to the lungs and the body. So here we've taken the front part of the lungs off so we can see the heart more clearly without the front of the lungs obscuring our view. And we can see that the heart has several surfaces. Now, the anterior, the front surface of the heart, is just underneath the sternum and the ribs, but of course they've been taken off here. So the anterior surface of the heart is what we're looking at. The inferior surface, that is the lower surface, anterior means front of course, inferior means lower. The inferior surface is the part of the heart, and it's between the apex and the right border. It's the part that's resting on the diaphragm, that flattened bit that you can see resting on the diaphragm. Exactly where I've got my line of inferior surface pointing to there. The right border is facing the right lung, and the left border is facing the left lung. So they're the sort of anatomical relations of the heart. Now, the heart's about 12 centimetres long and about 9 centimetres at its widest part. And it's located in this cavity called the mediastinum, this central partition separating the two pleural cavities. Now, the pleural cavities, the pleural membranes are surrounding the lungs. So there's a separate pleural membrane surrounding each lung. So the lungs are in the pleural cavities. The lungs are underneath the pleural membranes. So this area, the mediastinum, is containing the heart and the major vessels. So we see the arch of the aorta, and just to the right of that we see the superior vena cava. So the heart and the major vessels are in this mediastinum. And it's an anatomical region, and it's going from the sternum at the front to the vertebrae at the back, so it's going through the depth of the chest. And it's going from the first rib to the diaphragm. And you can see I've labelled the first rib there, and you can see where the diaphragm is. So that area is the mediastinum. And we can see the ribs on the outside there. On the left I've labelled the first rib number 1. And you can count the ribs down 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The first 10 ribs are the ribs that are connected to the sternum. The 11th and 12th ribs on either side are sometimes called floating ribs because they're not connected to the sternum. Now here we've zoomed in a little bit and we've taken the anterior surface of the heart off so we can see the chambers in the heart. And we notice on the right side there's the superior vena cava. This is the large vein bringing blood back from the two arms and the top half of the body. Now, in this model, vessels which are carrying deoxygenated blood are blue, and vessels which are carrying oxygenated blood are red. It's not quite that simple because in fact the blood in the veins is still about 70-75% oxygenated. So it's relatively deoxygenated. But to differentiate, we draw the vessels carrying deoxygenated blood in blue and the vessels carrying oxygenated blood in red. And in the systemic circulation, it's the arteries that are red carrying the oxygenated blood and the veins, which are blue, carrying the deoxygenated blood. So we see the superior vena cava carrying the blood from the top half of the body, and there's actually an inferior vena cava as well, opening into the right atrium separately, carrying blood from the bottom half of the body. So the superior and inferior vena cava are draining deoxygenated blood into the right atrium. The atrium is the receiving chamber. From there, the blood goes through the atrioventricular valve. So the atria are at the top, the ventricles are at the bottom. The valves between those two are the atrioventricular valves. And the right atrioventricular valve is the tricuspid valve, because it contains three cusps. So the blood can flow from the right atrium freely through the tricuspid valve into the right ventricle. But when the right ventricle contracts, that increases the pressure in the right ventricle. And when you increase the pressure in the right ventricle, that will close off the tricuspid valve, preventing the regurgitation of blood from the right ventricle back into the right atrium. In other words, the blood can flow from the atria to the ventricle, but not from the ventricle. It can't regurgitate back into the atrium. And if it did go back, as we'd say, that's regurgitation, and that is an abnormal situation. So physiologically, a valve ensures one-way flow from the atria to the ventricles, but not from the ventricles back to the atria. And then when the right ventricle contracts, the blood, still deoxygenated of course, is going to go out of the pulmonary artery. And the pulmonary artery is taking blood to the lungs. And we notice that the pulmonary artery is in blue because the blood it is carrying is deoxygenated. It's still deoxygenated blood. But it's an artery because it's carrying blood away from the heart. So by definition, an artery is any vessel carrying blood away from the heart. A vein is any vessel carrying blood towards the heart. But we see the pulmonary artery is blue because it's carrying deoxygenated blood away from the heart to the lungs in order to be oxygenated. Now moving to the left side on this model, we see the pulmonary artery. And what we're actually looking at there, what I've labelled is the main trunk of the pulmonary artery. This actually goes back a bit, but very quickly it divides into two because a branch of the pulmonary artery goes to each lung. And then below that we have the pulmonary vein. Now the deoxygenated blood is going to be carried by the pulmonary artery. The pulmonary artery divides into two, perfusing both of the lungs. The deoxygenated blood is going to go through the pulmonary capillaries. There it's going to come into very close contact with the oxygen in the alveoli, and it's going to be oxygenated as the oxygen diffuses from the alveoli to associate with the hemoglobin of the red cells, that is, with the hemoglobin in the erythrocytes. And at the same time, it will give up carbon dioxide from the blood into the alveoli to be exhaled. So that means that when the blood has been through the pulmonary capillaries, it's going to be fully oxygenated. And almost fully oxygenated, 88, 99, even 100% oxygenation. is quite normal. If you put an oxygen saturation probe on your finger, take a few deep breaths, it'll go up to 100%, meaning the lungs are working with 100% efficiency, which is quite amazing. So the oxygenated blood is going to go back to the heart via the pulmonary veins. And the pulmonary veins are bright red because they're carrying this fully oxygenated blood, even though a vein, by definition, is a vessel carrying blood towards the heart. And there's 2 pulmonary veins from each lung draining back into the left atrium. So the 4 pulmonary veins are draining directly back into the left atrium. From there, the blood is going to go into the left ventricle through the mitral valve. The mitral valve has 2 cusps, so it's sometimes called the bicuspid valve. But that is the left atrioventricular valve, taking blood from the atria through to the ventricle. Again, allowing the blood to go from the atria to the ventricle, in this case from the left atrium to the left ventricle. But then when the left ventricle contracts, that's going to slam that valve shut, preventing the regurgitation of blood from the ventricle back to the atria. But when the left ventricle contracts, that's going to open the aortic valve at the start of the aorta, and the blood that is contracted, when the left ventricle contracts, the blood that is ejected as a result of left ventricular contraction is going to go into the aorta. That is the systemic arterial circulation. Now here we've taken the heart out of the model altogether, and we can see the structures around the heart and the structures under the heart. So we notice the right lung with the bronchial passages and the pulmonary artery, or branches of the pulmonary artery and branches of the pulmonary vein. We notice the superior vena cava, which would drain into the right atrium. The trachea is coming down behind the major vessels, and we notice that that divides into the right and the left main bronchus going into each lung. The diaphragm at the bottom and the right lobe of the liver, the left lobe of the liver on the left side, of course. We notice the left lung, the left main bronchus, and then we see the thoracic aorta. So after the aorta has left the left ventricle, it arches up and round and then goes back down behind the left main bronchus. And then just to the right side of the thoracic aorta, we notice the esophagus, the food pipe, carrying food down through the thoracic cavity, through the diaphragm to the stomach. And this whole space, of course, we now know is called the mediastinum, containing the heart and the large vessels. Now this view is looking from the top into the left atrium. And we notice that there's 2 pulmonary veins on either side of the left atrium entering into the left atrium. So there's 2 large veins from the right lung and 2 large veins from the left lung that both drain directly into the left atrium. And at the bottom there you can see the mitral valve. So if you put your finger down through there, you would be going into the left ventricle. And we also noticed labelled PA is the pulmonary artery. So the main pulmonary trunk is leaving the right ventricle. That quickly divides into these 2 large branches, one large branch taking blood into each lung. We're looking at the heart from the bottom, that is from the apex up the way. And just to remind us, I've put a big R and a big L on the screen, so the R is the right and the L is the left side. So looking at the right ventricle, we see the tricuspid valve bringing blood from the right atrium through to the right ventricle. When the right ventricle contracts, that blood is going to go out of the pulmonary valve. So this is the pulmonary arterial valve, or the pulmonary artery valve. In the old days it used to be called the pulmonary semilunar valve. But this pulmonary valve is allowing blood to go from the right ventricle through into the pulmonary artery. So when the right ventricle contracts, it's going to slam shut the tricuspid valve, simultaneously opening the pulmonary valve, allowing the blood to go out into the pulmonary artery. But then when the right ventricle has finished contracting, the blood can't go back out of the pulmonary artery, regurgitating back into the right ventricle because the pulmonary valve will shut. So again, the pulmonary valve is ensuring one-way flow of blood, but this time it's from the ventricle into the pulmonary artery, preventing regurgitation from the pulmonary artery back into the right ventricle. Now, moving from the right to the left side of the heart, we see the septum. Now, a septum is a structure which divides, and this is the interventricular septum. That is the septum dividing the right and the left ventricle. And we notice it's muscular and contains myocardium. Now, in living specimens, the left ventricle is noticeably thicker than the right ventricle. That's not really brought out in this model. But the left ventricle is much thicker. There's a much thicker layer of muscle, a much thicker layer of myocardium. But on this model, we notice the mitral valve, the bicuspid valve, allowing the free flow of blood from the left atrium through to the left ventricle. When the left ventricle contracts, that's going to close off the mitral valve, preventing regurgitation of blood from the left ventricle into the left atrium. But we notice the aortic valve. So when the left ventricle contracts, increasing the pressure in the left ventricle, that will open the aortic valve, allowing the blood to go from the left ventricle out into the aorta. And we notice that the aortic and the pulmonary valve are both tricuspid. They both have 3 cusps. So of the 4 main valves, the only one with 2 cusps actually is the mitral valve. Now, this open section of the heart shows us the tricuspid valve and the mitral valve, and we notice that there's chordae tendineae, or tendinous cords, connecting the valves to papillary muscles. Now, when the atrioventricular valves are open, that's the tricuspid and the mitral valve, when they're open, the rounded end of the valves projects down into the ventricles, as we see. And this means the blood can flow freely from the atria through to the ventricles. So when the ventricles are relaxed, the papillary muscles are also relaxed. They're not in a contracted state. And the chordae tendineae, the tendinous cords, are loose, they're slack. But when the ventricles contract, the pressure of the blood slams shut the valves. But because the valves aren't muscular, they just kind of flap around in the flow. They're not muscular structures. So the high pressure in the ventricles would tend to push the valves up so that the open cusps of the valve were up in the atria. And that would allow regurgitation of blood from the ventricles into the atria. So we don't want that. So the length of the tendinous cords is just the right length, so that when the valve cusps meet in the middle, that the tendinous cords stop them from flapping back into the atria. And at the same time, the papillary muscles contract. So the papillary muscles contract at the same time as the ventricles contract. And this further pulls on and tightens the chordae tendineae to stop the cusps of the valve floating back up into the atria. So everything's coordinated so the valves are completely shut, not allowing any regurgitation of blood. So that prevents that, because the pressures in the ventricle are very high, and if we didn't have this mechanism, then the valves would simply go straight through the opening, point in the other direction, and allow regurgitation of blood, and the heart wouldn't work at all. And of course, this can happen. This is valvular failure if this happens, which is a deeply pathological situation. Now here we notice the trabeculae carni, the small fleshy beams. And the inside of the heart is lined with the endocardium, but it's not smooth and flat. It's arranged in these series of grooves and ridges. And the purpose of this seems to be that when the heart is contracting, if there were two smooth walls on either side of the ventricle, there would be a tendency for the two sides of the ventricle, that is the side of the ventricular wall and the side of the intraventricular septum, to stick together. There would be a kind of suction effect. And we don't want that, because we need the heart to refill when the heart is not contracting during the period called disystole. So the ventricles fill up for the next systolic contraction, the next time the heart needs to contract. So they prevent that suction effect. And they also ensure smooth flow of blood through the ventricles. There's a hydrodynamic function of the trabeculae carni as well. So here we see some of the large vessels which are close to the heart. Now, what I've labelled brachiocephalic trunk there is actually the brachiocephalic trunk artery. And the reason this is called brachiocephalic is because that brachiocephalic trunk in a short while will divide into two other arteries. One is the right common carotid artery, and it will also divide into the right subclavian artery. So the right subclavian artery goes underneath the clavicle and on into the arm. So it's called brachio because it's going to go into the brachial artery in the arm, and it's called cephalic because cephalic is to do with the brain, and of course the carotid artery is going on up to the brain. Then beneath that we have the brachiocephalic veins. There's the right and left brachiocephalic vein which drain into the superior vena cava. And we notice the arch of the aorta carrying blood out of the left ventricle, and the main pulmonary trunk which divides into the right and the left pulmonary artery. And the pulmonary trunk, of course, leaves the right ventricle. But carrying on with the arteries, we've got the brachiocephalic trunk artery. Then we've got the common carotid artery, and that is actually the left common carotid artery. So it's interesting that the right common carotid artery breaks off the brachiocephalic trunk, but the left common carotid artery leaves the aorta directly. And then the third major vessel there at the top of the aortic arch is the left subclavian artery, going underneath the left clavicle and taking blood into the left arm. And we can also see the esophagus there in brown. Behind that you can probably see the rings of cartilage in the trachea in blue. And further down we can see two of the pulmonary veins, the left pulmonary veins. But there's two right pulmonary veins as well. So the blood flowing towards the heart in the veins and going away from the heart in the arteries. Now the myocardium is a metabolically active tissue, of course, because the heart is contracting 70 times a minute throughout life. And because it's metabolically active, it's going to need a good oxygen supply and a good supply of nutrients, and it's going to need to take the waste products of metabolism away from the myocardium. So the coronary arteries are the arteries that supply the myocardium itself with blood. And they're called coronary because they form a crown shape around the heart if you hold the heart upside down. Or so some people have thought, this crown-like appearance as the arteries surround the outside of the heart. Now, two main coronary arteries, the left and the right coronary artery. And these left and the right coronary artery leave the aorta directly, and they are the first vessels to leave the aorta. So we see the right coronary artery there supplying blood to the right atrium and to the right ventricle before going round to the posterior surface of the heart. And also the right coronary artery goes down towards the cardiac apex, the inferior areas of the myocardium. That's why if the right coronary artery is blocked, it often causes an inferior myocardial infarction. And blockages high up in the right coronary artery that can affect the right atrium have the potential to affect the sinoatrial node, or the pacemaker, which is located in the right atrium. On the left side, the left common coronary artery leaves the aorta, but then fairly quickly it divides into two, into the anterior interventricular branches of the left coronary artery. Now that is going down the front of the left ventricle, and it's sometimes simply called the LAD, the left anterior descending artery, but its precise name is the anterior interventricular artery because it's going down between the ventricles, but it's giving most of its blood supply to the left ventricle. And then the other branch of the common left coronary artery is the circumflex branch, and that is taking blood round the back of the heart to the posterior cardiac surfaces and the posterior myocardium. So absolutely vital that these coronary arteries are patent. If the anterior interventricular artery is occluded, or that is the left anterior descending, then that often causes anterior myocardial infarctions because it's the front wall of the heart. And if it's the circumflex branch, that will tend to affect the lateral leads, causing a lateral myocardial infarction. And if the common left coronary artery is blocked, that can affect the left anterior descending and the circumflex. Then that can cause a large anterior lateral myocardial infarction.